So thank you again for the opportunity to talk once again about how to get great results with micro-phlebectomy, my disclosures. For once, rather than talking about the technical pearls for micro-phlebectomy, I will talk about how to select in daily practice the good patients to get the best results in case of saphenous reflux with micro-phlebectomy. Because even if you master the technique, you need to select properly the patient to get the good results, in order to avoid saphenous ablation. And if you can, you want to see the video, you have the QR code, and it will be displayed at the top of my slide all over the presentation. So several authors have published their own criteria of saphenous preservation. We have gathered all of these criteria in this paper a couple of years ago, and we have integrated these criteria in our database. So they are systematically filled in for all patients with varicose veins, and therefore we wanted to study the relevance of these criteria after years of daily practice. So we reviewed all patients treated for varicose veins during 4 years, focusing on patients with varicose veins and isolated GSV reflux, meaning with a competent saphenous vein, and it was a patient never treated before. So 840 limbs were treated in the patient selected, and the treatment consisted in micro-phlebectomy with saphenous sparing according to the ASVAR principle in 87% of the cases, and a GSV saphenous ablation by laser in 13%. The comparison of both cohorts according to the treatment performed showed that the patients treated by ASVAL were predominantly female, younger, with lower BMI, more frequent C2, less frequency for C6, less frequently symptomatic, with more often competent junction, and with less extended truncal reflux at the thigh and calf, with a lower varicose reservoir ablation to make. So the comparison of saphenous sparing selection criteria showed that all of the hemodynamic criteria were more frequent in the ASVAL group, with a very high significance, as it was for the clinical criteria, at the exception of nulliparity. Interestingly, we observed that 6 criteria listed here were present more often than the other in the ASVAL group. The midterm outcomes of this patient treated by micro-phlebectomy alone showed that the reflux was abolished in 86%, with a symptom release and cosmetic improvement in 97%, the presence of residual or recurrent varicose vein in 5%, and a need of an additional major procedure in only 1 case, consisting in limited phlebectomy. The positive predictive value for the 6 more frequent selection criteria was very high, between 87 and 99% for the GSV reflux abolition, between 96 and 97% for the symptoms improvement, and between 97 and 98% for the cosmetic improvement. And when the 6 criteria were present all together, it was even higher, on 90, 97, and 98%. So looking at this result, we can say that the saphenous sparing criteria were relevant for the selection of cases eligible, more frequent in the ASVAL group with highly significant matching with less advanced varicose disease stage, with 6 criteria that seem to be particularly relevant with very high positive predictive value for good outcomes. We also observed that we get better results than in previous publication of isolated micro-phlebectomy for all outcomes, and it is probably explained by the fact that the patients were not selected or unclearly selected in previous publications, including ours. So, in conclusion, the pre-op saphenous sparing criteria are relevant to select the patient eligible for micro-phlebectomy alone, since they are matched with less advanced varicose disease stage. 6 of them seem to be the more relevant for this selection, with a very high positive predictive value of good outcomes. And finally, the use of these specific criteria since 5 years in our daily practice enable us to get great results after micro-phlebectomy with saphenous preservation. Thank you for your attention.